In the next few slides, we are going to discuss deficiency anemias, their causes, and to understand causes, clinical approach and management of an infant or child with iron deficiency anemia or with megaloblastic anemia. WHO definition of deficiency anemias is that they are conditions where the hemoglobin content of the blood is lower than normal as a result of deficiency of one or more of the essential nutrients, regardless of the cause of such deficiency. Iron deficiency is the most common frequent cause, and less frequent are folate and vitamin B12 deficiencies. Concerning the iron deficiency anemia, what are the recommended dietary allowance of iron for infants and children? If we see from this slide that the requirements in infants are higher than in later in life, and then they become to increase again during adolescence because of the increased requirements during the adolescent growth spurt. However, only 10% of the consumed iron is absorbed. This figure we are going to explain in the face-to-face session. This explains the body iron distribution and storage. When you take iron, it's absorbed in the duodenum, and then it passes to the circulation and is carried by plasma transferrin. Plasma transferrin carries the iron to be used in the bone marrow for the erythropoiesis, and it is carried to the muscle for the myoglobin. The excess iron is stored in the liver in the form of ferritin. Ferritin is some sort of iron which can be used. It can be changed back to iron for utilization when there is iron deficiency. Also, when the red cells, the lifespan of the red cells ends by 120 days, they are phagocytosed in the reticular endothelial system, and the released iron passes back into the circulation. So by the end result, the amount of iron which is excreted in the stools is almost equal to the amount of iron intake. So we are in a state of balance of the iron state. So in the pediatric age group, we can make the statement that the requirements of iron are 1 to 2 milligrams per kg per day. Only 10% is absorbed. Concerning the difference between breast milk and cow milk, both of them contain the same amount of iron, 0.5 to 1.5 milligram per liter. However, iron absorption is almost 50% from breast milk compared to only 10% from cow milk. The iron-containing foods are divided into two groups. Groups where the iron is produced from the heme. These are the animal sources, and group where the iron is not related to heme. It's not in the form of heme, and this is mainly from vegetarian sources. What's the difference? The difference is that the iron in the red meat is absorbed up to 7 times more easily than the non-heme iron, and we should consider that in vegetarian food, the fiber, the phytates, the tannins, the oxalate, they bind iron and they prevent absorption of the non-heme iron. Iron deficiency in infants and young children results from the rapid growth and the inadequate intake, so the nutritional factors are important. However, in older children and adolescents, the most common cause is blood loss, possibly due to cow milk protein intolerance. Cow milk protein intolerance, this occurs even in infancy, so we cannot speak of older children and adolescents. Parasitic infections and infestations like ankylostoma is a cause of iron deficiency anemia. Inflammatory bowel disease like ulcerative colitis and Crohn's disease, menorrhagia in adolescent females, and the intake of aspirin, non-steroidal anti-inflammatory drugs causing gastritis. When we want to diagnose deficiency anemias, the iron deficiency anemia, number one, we take the dietetic history, gestational age, feeding habits, and supplementation. Why? Because exclusively breastfed infants for more than 6 months and preterm infants for more than 2 months, they will develop iron deficiency if they are not supplemented with iron after this age. Why? Because the main storage of iron in the fetus occurs in the last 3 months of gestation. So if the baby is delivered preterm, his stored iron is low, and he will need to be supplemented with iron after 2 months if he is only breastfed. Vitamin B12 and folate are adequately supplied by breast milk and fortified formulas. However, the mothers who are severely B12 deficient this can lead to pernicious anemia in the exclusively breastfed baby. Does this occur if the mother is iron deficient? No. An iron deficient mother, her child is not liable to iron deficiency because the iron content in the milk is not affected by the mother's iron status. Clinical manifestations of iron deficiency, they include tissue effects of the iron deficiency because the iron is important for many enzymes in the body, and deficiency, even in the absence of anemia, will result in GIT disturbances like anorexia. Lipika means the child tends to eat abnormal things like earth. Cardiovascular manifestations, tachycardia, musculoskeletal system, decreased muscle work, impaired immunity, in neutrophil dysfunction and mild low lymphocyte count. The most important is impaired intellectual functions, cognitive functions, and behavioral disorders. In severe forms, we may get koilonychia, which is spooning of the nails. Plus the other manifestations of anemia. The most common symptoms are breathlessness, lack of energy, dizziness, headache, irritability, irregular menstrual cycles, and by examination there is abnormal pallor of the skin and the mucous membranes, tachycardia, glossitis, and the most important for children is delay in growth and development. So what are the laboratory tests we are going to request? We are going to request a blood smear, and we are going to look at blood indices. We expect to find what we call hypochromic microcytic anemia. Hypochromia results from a decreased hemoglobin in the red cells. So the mean corpuscular hemoglobin is expected to be less than 27 picograms. Mean corpuscular hemoglobin concentration less than 30%. Microcytosis means that the mean corpuscular volume will be less than the normal for the age of the child. And there is what we call the red cell distribution width. It will be wide. It's a reflection of the variability in the size of the red cells, what we call anisocytosis. This hypochromic microcytic anemia is not specific to iron deficiency, can occur in other conditions like in thalassemias. So it's important to go to an iron profile. Iron profile to know our iron status of this child. We do serum ferritin, it's decreased, storage is decreased, serum iron in the circulation is decreased. Another factor is to assess the transferrin saturation with iron. It will be found to be decreased, it's 16% or less, and there is an increase in the iron binding capacity. We are going to explain this in the face-to-face session. But if you look to this blood film, this is a normal red cell. And we see the red cells almost the same size, the same shape, and there is a central pallor. If you have iron deficiency anemia, because of hypochromia, find that the central pallor has increased. There are variable sizes of the cells, which we call anisocytosis, and various shapes, which we call poikilocytosis, and this is very characteristic. So now my child is diagnosed as iron deficiency anemia. What's the appropriate treatment? Please look to the deficiency anemias part